Doktor CARBAJO misafirimiz sabah yine webinarla uluslararası bağlantısı vardı. O nedenle bizden sonra sunmak için izin istemişti. Şimdi kendisini davet ediyoruz. Buyurun Doktor CARBAJO.
Good morning. Thank you. Sorry for my delay. But now I will try to explain this important item about the metabolic and to try to make a comprehensive, a more comprehensive knowledge about this procedure, the one anastomosis gastric bypass in the metabolic in their metabolic effects. So it is important to know that what kind of disease we are working. This is very, very important to know, mainly for younger surgeons, that it's very, very important to know that we work for patient who has chronic inflammatory metabolic disease. And this is not only chronic, it's chronic, it's incurable. This is a very important item. If our patients has this kind of serious disease, we need procedures with high metabolic power in order to control, to resolve as much as possible, not definitively, of course, but during the time, remain long-term effects, metabolic effects, and weight loss in long term, as well as comorbidities, resolve comorbidities. So, look at the evolution, the pandemic evolution in the world. This is the date only until 2018, but increasing in the world. This is the real pandemic actual in the world, obesity. And what can we consider as ideal in metabolic or bariatric? This is very important. More than 10 years evolution. And this is the problem, because practically, when these fingers is possible to knowledge the papers that had results, long-term results, more than 10 years. A few surgeons in the world can give their results more than 10 years evolution. This is the problem, because we are trying to control an incurable disease. So for this, it is very important the studies more than 10 years. Majority of studies published in the literature is 1 year, 2 years, 3 years, short term. But short term, the value, this is in the nebulous. The value is shorter. We need long-term, if it's possible, more than 10 years. That is very difficult to make a follow-up, a complete follow-up. Fortunately, the Center of Excellence, like our center, we have the compromise to make at least a 75% of follow-up in all of our patients. So for this, we stay in condition for to make results more than 10 years. And this is other topic very important, not only weight loss, comorbidities, resolve or control the comorbidities more than 10 years. So, look at this graphic. This is in red, metabolic surgery, in blue, bariatric. But look at this. This is another graphic. What kind of surgery we perform? Metabolic. And this is an important item for understanding in our minds. We perform metabolic surgery. And only in a few patients here, female with a BMI no longer, we can speak about bariatric. But all our patients, 95% of our patients have had diabetes, hypertension, dyslipidemia, a lot of comorbidities. And this is metabolic surgery. This is another important item. So look at here, this picture. What was the first one anastomosis gastric procedures performed in the world? 54 years ago. 54 years ago. Mason, the old Mason loop. As you know, the Professor Mason was named, in my opinion, correctly, the father of the bariatric surgery in the world. But 54 years ago, he described this loop, jejunal loop, one only anastomosis. Unfortunately, this procedure was very advanced in the time and had another multiple complication and was not possible to follow this. But 30 years later, appeared this for my friend Robert Rollege. It's different because the pouch, this is not in horizontal position, but it is in vertical position. And he found this concept accidentally because Robert Rollege, this is not a surgeon, a digestive surgeon. This is a surgeon for trauma. So it was an accidental item, but this is a bit of philosophical stone because it eliminates the alimentary limb and perform this procedure that he published in 2001, and in 2002 I changed this mechanism because when I started to work with this, I tried to start it with this procedure in order to avoid the complication derived to the Russian Y. I had during more than 10 years, I worked in thousands of patients with Russian Y gastric bypass, including in open surgery in the pre-laparoscopic era. But complication, you know, it is very important, and also weight loss. So for this idea enter in my mind, but needs to modify in this graphic that this is you know by my conference yesterday. So eliminate this the philosophy. It's eliminate the alimentary limb and perform an biliopancreatic limb longer, but also need a very long tube and this building construction to perform a more safe operation. So there are differences. This is not the same operation. There are two different operations. Both have a hypoabsorptive operation. This is another important point, but OAGB is higher hypoabsorptive operation. But the positive aspect, there are a lot, but in all these topics that appear here, that all of them this is true, but I need to explain mainly less perioperative complication and restriction without obstruction, more digestive comfort and less risks of leaks and stenosis. So this is another positive aspect. This is an operation highly reproducible. There is another techniques that hypersorptive techniques, as the duodenal switch, for example, or including recently the SADIS procedure. But the problem is the reproduction. Is not all the surgeons can the possibility for reproduce this kind of procedure for the complexity of the anastomosis and the time in the surgical room. But this is a highly reproducible, and this is especially in super obese people, obese patients, because we can choose a very long biliopancreatic limb and a very short common limb. So for this, in this patient super morbid, this operation is superb, believe me. And mainly in the control of type 2 diabetes. I explain in the next slide what is the main reason because the type 2 diabetes practically disappear with this. This is, in my opinion, the best operation for the control of diabetes. So there are studies different, mainly for the Italian school of Tolone and colleagues that working a lot about the esophagogastric changes, and they are demonstrated that there are low intragastric pressure, low pressure of the lower esophageal sphincter, low gradient of esophagogastric pressure, the decrease of the mid score, and great fall of gastric reflux and weak alkaline reflux. So also in this study, the conclusion is that the OAGB does not compromise the function of esophagogastric junction and do not increase the gastroesophageal reflux, and also biliary reflux. Biliary reflux practically has not been demonstrated so far with but this is very important when the technique has been performed correctly. If you perform a short pouch, if you not have experience in this technique, it is possible to need to convert it a Russian Y or another procedure. But with the technique is performed correctly, biliary esophagitis, believe me, it's not possible. In all my thousands and thousands of patients operated so far, there is no case. So, has demonstrated excellent outcomes in long-term permanent weight loss and remission of improved comorbidities. And also comparative studies have demonstrated that the efficacy lower morbidity with OAGB. So for this is a superb and simple option to revise other surgeries, mainly sleeve gastrectomy. I think this is possible in the future. The main operation for converted the weight regain after sleeve gastrectomy. I don't recommend converted to Russian Y if the problem is weight regain. If the problem, of failure of the sleeve gastrectomy is reflux, is possible that the Russian way this is a good option. But if the problem is weight regain, Russian way is not a good option. My recommendation is performing a guan anastomosis gastric bypass because it's very simple operation after a sleeve gastrectomy, and the results are fantastic, fantastic. If, almost in my experience, believe me that this is true. So this is an important slide because what is the mechanisms that are involved in the metabolic surgery? There are a lot. As you know, there are a lot. There are mechanisms that we know perfectly, and another mechanism that is not so good with knowledge sufficient so far. So there are hormonal signals. There are the role of the bile acids, glucose uptake, incretin effects. There is very no, but also microbiota. But there is a mechanism that this is here, the intestinal mechanisms. Intestinal mechanisms is not so sufficient study, but this is very important in the metabolism of the glucose and the results after this the surgery in the hypoabsorptive procedures. So in the sleeve we have here the hormones ghrelin. But the ghrelin, you know that appear more or less 1 year later. The level of ghrelin started to rise constantly. So for this, the permanent maintain of weight loss during the time in this operation, in my opinion, is not sufficient. We have here gastric bypass. The hormones, not only the ghrelin, but the incretins have any effect. But this is not complete. This is reduce the effect of incretins during the time. So for this, in diabetes type 2, the incretin effects are reduced. And in this graphic, you can see, in this graphic, you can see the glucose, this in red, in the normal anatomy. In the normal anatomy, the glucose is absorbed here, in the jejunum. And, but after surgery, in the one anastomosis gastric bypass, the glucose is absorbed in the terminal ileum, because our anastomosis is gastroileal, no gastrojejunal. It's gastroileal. So for this is healthy patient because the incretins effects and the key iles cells are very active because the food enters directly in the terminal ileum. So for this, the metabolic power is higher. In this graphic, you can see the postprandial response to glucose. There is more effective. This is a study that was performed a long time ago, but it's more effective in the OAGB. And also in the metabolism of the glucose in the liver. The liver receives less amount of glucose. So for this, through the Krebs cycle, the cholesterol, the high density cholesterol, it's low. So for this, the metabolism of the lipids is very low, and this is a very metabolic operation. In this graphic, this is a study that the first study in animals with the three most important procedures that performed today in the world. It is the sleeve and Russian Y and one anastomosis gastric bypass. This procedure was performed in animals for compare the change in the small bowel. So the first study was performed by a Spanish colleague that working with us during about 1 year, and in this moment working in French. And his doctoral thesis was based in this kind of study that after the Chevalier school in Paris developed more than. So if you can see here, they produce the high hyperplasia, compensatory hyperplasia in the enterocyte cells, but this is the ileum. In the ileum, the increase of the hyperplasia compensatory in the ileum, this is in an OAGB bigger than the sham, of course, and than the sleeve, and the sleeve is not, and the Russian Y. And this is in human. When we translate to the humans, this is the ileum in the normal people, and this is the after surgery. In this image, we can see that the hyperplasia compensatory in the ileum is very, very intense. So for this reason, after appear this component, this important component, this molecule that this is named as GLUT1. This is GLUT1. This is a protein that working that a glucotransporter into the brain. Usually, this GLUT1. This is only in the brain for transporting more quick the glucose into the cerebral cells. But after surgery, what happened? After surgery, appear in the small bowel. After OAGB, the GLUT1 increase in the small bowel, not the level of the brain, but increase a lot. So, what happened after? This slide is very, very important for understanding. This is the change, the most important change that are produced after surgery. This is what happened after surgery. OAGB generates a small bowel hungry, because the most important part of the small bowel is not to receive glucose. So the rest, the common channel, generates a very hungry small bowel, hungry intestine. So the cells are hungry for glucose, and after appear the GLUT1, and the GLUT1 remove the glucose of the blood and transport, make a transportation to the glucose into the cells, into the small bowel cells, into the enterocyte. So the GLUT1 remove the glucose to the blood, and the way of the glucose is different. Before the surgery, the glucose go to the small bowel, to the blood, but after surgery, the glucose go to the blood, to the small bowel by the GLUT1. So, for this reason, the control of the levels of the glucose and the blood is very high, very maintained over the time, and this is a key. This is one of a key of success of this kind of surgery in the control of the diabetes type 2.
Sorry, sir, we are run out of time.
Yeah, if you can, I finish, but as you want. we are a lot of items for, but I am trying to be more quicker. Yeah. Yeah, this is the problem of Uruguay. You know, a lot of complication, 30 possible risk complication against 4 possible complication. You know the HIGA paper, measurements of success remain in the nebulous. This is very important in 10 years a lot, but we need to be caution with the sleeve, because not only the complication, but the problem is the weight regain and Barrett. And Barrett, yeah, there is studies with very high levels of Barrett, and so we need, if we compare restrictive surgeries and mixed surgeries like Rus and Y, this is in the same because the both procedures can rise about more than 60% of excess BMI more than 10 years. But the real comparative in the OAGB is with duodenal switch, because the both procedures can reach more than 70% excess of BMI during more than 10 years. And this is a lot. After one anastomosis gastric bypass appear a lot of procedures, but the most important is the common channel. Yeah, as I comment yesterday, the common channel after biliopancreatic limb and after the pouch. But the most important item in metabolic surgery is to know the common channel. So why this is important, the common channel? Because there are a lot of procedures that the common channel is a no. Also in mini-gastric bypass, it's a no. And this is very important. In SADIS, it's a no, the biliopancreatic. But this is very important to know both biliopancreatic and common channel. This is very important. And this is the relationships in our study that I published recently in our study. This is the ratio, and to maintain 200, 230 centimeters for common limb, we can have weight loss maintained more than 5 years in our study with a BMI about 25 or less, and without nutritional problems. This is the efficacy versus risks, and this is our paper that more than 10 years results. It was one of the most readers in the world in 2018. This is our results that this is published. This is no. You look at here the remission, and this is our first 1,200 patients. That was a study more than 10 years. And also here in this another study, 12 years maintain an excess BMI more than 75%. And this is the evidence of Reinhold's classification. But in another study performed for us over the level of the glucose, as resolution of the glucose, problems of the glucose is very high. As I comment also with the lipids, the metabolism of the lipids, this is the same. In children and adolescents, I recommend this kind of operation in adolescents because our results are very good in the long term. And you can see this graphic. This graphic is the European database register of IFSO Center of Excellence. The Center of Excellence, we have the compromise to meet our data in this database. This is the biggest database now in the world, and this is the evidence. This is the excess weight loss comparative, and this is the excess BMI loss comparative more than 5 years. And also the remission rate of diabetes is the difference is very clear, but mainly in dyslipidemia. This is impossible practically to obtain in another techniques, and also 90 years after, to maintain 70% of weight loss, and also resolution of comorbidities. And this is the journey. The journey was very hard. This is the start of the journey, and the evolution, and today, last I wrote in an editorial of International Bariatric Club that we had a technique in our hands that we could perform on patient in a framework of efficacy and safety. So this fact lighted up the way forward. So, and already is a true IFSO option. This is the recognized metabolic and bariatric procedure in 2090, and I had the opportunity to work in this task force. But now appear recently in July this year the second update, the second position IFSO statement about OAGB, that also I got the opportunity to work in the task force, and the OAGB should remain. OAGB, other names disappear, only rest OAGB remain the official IFSO approved identifier, and this is very important. The recommendation of the IFSO: short operative time, low operative complication rate, good weight loss, and good comorbidity revision, and very important, biliary reflux does not seem to be a major issue, and also this is important, that should have at least an annual nutritional review. This is another important conclusion of the IFSO update position statements on OAGB this year. So this is the conclusion that you can see. I commented during the conference, and so I think this is no. But OAGB has showed the best enterocyte growing model and the most efficient metabolic control with the GLUT1 increased levels, and a safe and effective, powerful alternative bariatric and becoming mainstream in bariatric surgery. So, but standardized teaching and performance, this is mandatory. It is not it's necessary to work, and this is the draw that you know, and thank you very much for your attention, and I'm sorry for the time.
Biz de çok teşekkür ediyoruz Doktor CARBAJO'ya bu detaylı bilgileri birinci ağızdan duyabilmek için kahve molasından süre çalmayı göze aldık. Çok teşekkür ederiz. Bir soru alalım lütfen, çünkü bir konuşmacımız daha var. Cüneyt'in de affına sığınıyoruz. Onu birazcık komplikasyonlardan da çalacağız galiba süre olarak. Varsa eğer sorunuz CARBAJO'ya bir soru alalım. Evet, dün teknikle ilgili püf noktalarını, bugün de sonuçlarını bize bütün detayıyla sundunuz. Çok teşekkür ederiz. Tekrar inşallah başka vesilelerle beraber oluruz. Çok teşekkürler Dr. CARBAJO.
Much for your attention.